Hey guys, welcome back to the Life of a Doctor's Wife. Last week I shared what the first month of residency has been like from my perspective as the spouse. Today I thought it would be fun to bring on the actual resident, my husband Dave, to answer some of the questions I've been getting from all of you. We're only 1 month in, so we definitely don't have all the answers, but we wanted to share what this transition has really looked like, what has surprised us, and what we wish we knew before residency started. So, Dave, welcome back to the podcast.
Glad to be back.
Let's get into it. So, what's been the biggest surprise about residency?
I say probably the biggest surprise would be doing things that are not necessarily medicine in the ER. There's just a lot of like little problem solving things that you have to do that I guess I never really considered as a medical student. And, you know, it's not things that they ever really bring up in medical school. So like, you know, the prescription printer is not working or the regular printer is not working, and you have to try and problem solve that and figure out like who to call to fix it. Or like calling patients' families and getting in touch with people who have information about patients, and you know, just a lot of things that you don't really realize go on behind the scenes, and, you know, things that need to be done to adequately care for your patients, but things that, you know, it's not something you can study for. It's not something you can read in a textbook. It's just kind of something you have to problem solve along the way.
Yeah. Was it hard to try to get into the mode of like walking into a room and being like, hi, I'm the doctor, like?
A little bit, you know, it's funny the first time you go and introduce yourself as, like, for me, Dr. Monty. I'm like, hi, I'm Dr. Monty. And I'm like, oh, that sounds a little bit weird coming off the tongue the first time. And then, you know, patients referring to you as doc, and you're like looking over your shoulder like someone else is going to be in the room with you. And you're like, oh, wait, no, that's me.
Yeah.
So it's cool though. And I think, you know, when you have that kind of relationship, it almost gives you a little bit more confidence kind of when you're talking to patients, because you're like, okay, I am the doctor. They're referring to me as such, and I need to take on that responsibility. So, you know, I think it's definitely a little jarring the first couple times, but you get used to it quick. And, you know, the way our program works, there's a good amount of oversight from the seniors and the attendings the first few shifts that you're on, but they give you your own autonomy pretty quick. You know, I've been just kind of learning on the fly, and yeah.
Was it weird saying Dr. Monty because like growing up in your household, Dr. Monty was always your dad? Like, is that weird?
Yeah, I don't think it's weird. I think it's more just like, you know, this was such a long journey, and my dad was someone that I looked up to for a long time and was striving to be like as a physician. And so now to, you know, hear people refer to me as Dr. Monty is really cool.
Would you say that residency is as hard as you expected?
I don't know that I have a great grasp on that yet. I think this month is so unique for us, the way that we do it. We have like intern boot camp. So we don't have as many clinical shifts, but we have a lot of like didactic and sim days. So it's a lot more like learning heavy and less like work heavy. So I don't know that I have a great assessment of how hard, quote unquote, it is yet. I know kind of from hearing stories of seniors and, you know, other residents that there's certain months that are going to be challenging. Like the ICU months are kind of brutal for us. But the general like EM months, I think, are going to be pretty manageable. You know, I don't think they overwhelm us too bad with shifts, and, you know, switching around your sleep schedule here and there is to be expected. I got a little taste of that this last weekend, and still catching up a little bit, but it's all part of the job. And yeah.
No, I think that's all really great. Because like you said, I think being in the emergency department is like what you wanted to do. So like you probably enjoy those days more and find them less challenging too.
Yeah.
Than like ICU, for example.
Yeah.
But what has...
Yeah. And I would say too, like, you know, when I'm on shift, like the shifts fly by. Like it's fun being in the ER. It's fun talking to everybody. It's fun seeing patients and caring for them. You know, but when I get home, I'm like, wow, I did a lot today and I really feel it. I'm like, man, I am beat when I get home, but it doesn't necessarily feel like hard work while I'm there, which is good.
No, that's good. What's been your favorite part so far?
I think my favorite part has just been kind of meeting all the people involved with the residency, from all the attendings that I'm working with to my co-residents. It's really cool to see people that have kind of similar personalities, similar interests, and similar sense of humor, that kind of thing. Yeah, getting to know everybody's been a lot of fun, and
Honestly,
yeah,
I've loved watching your confidence grow. I don't think you're anywhere near what you'll be in 3 years from now, graduating residency. But I think every shift when you come home, I feel like you have like a little bit more sense of confidence in you in being a provider, you know?
yeah.
What do you feel has been the hardest adjustment?
I think that the biggest adjustment has been the charting aspect. We have Meditech at our hospital, which is archaic. It works, but it's not maybe the best EMR to figure out. There's just like a lot of little quirks and things that you have to know, and boxes you have to click to do things, and orders that exist in there that you're really not supposed to use that have almost the same name as the orders you're supposed to use. So it's just a lot of things that like you don't know what you're supposed to do or not do until you have to do it. And then once you have to do it, you think you know what you're doing because you're like, oh, this is,
Right
wherever I'm
here.
supposed to order. It's right here. And then someone comes up and they're like, hey, we don't do that. That's not how we do it here. And you're like, oh, I'm sorry. So, it's just a lot of like nuances to the system that, you just kind of have to get used to. And that just comes with time and repetition.
No, for sure. I think also like the hardest adjustment like between all of us is like figuring out what day it is, because now that I'm not working and I think you have been switching back and forth between days and nights, and like this past week you started your long stretch on a Sunday, so then I thought it was like Monday that week, so then we were like a day ahead, and then I don't know, then we just got so screwed up.
The weekly calendar doesn't really exist in
No.
the ER. The weekends are a social construct, and doesn't the days off is the way that we have to phrase it, because I think I was off today and today was Tuesday, I think.
Yeah. Do you ever feel guilty being away from home?
I do, in a sense. Just like I know it's hard, like for you being at home with Mia all the time, and then especially like if I work a night shift and then I come home and I'm sleeping like right when she's waking up, and it's like I'm home but I need to sleep because I've been up for 24 hours. So I do feel a little guilty sometimes that there's a lot of time that I'm not able to spend with you guys just because I'm at work or sleeping and that kind of thing. But ultimately I think that that's kind of to be expected, out of anybody in residency or a career in medicine in general. I think we all kind of go into this field knowing that we're going to miss a lot of time with family. You try and limit how many things you miss and how much time you miss as much as you can. But I don't think that ever takes away from, feeling a little bit guilty that you're at work so long.
No, I know we miss you a lot, but I think it's been like a good balance though, because I feel like even when you come off of nights, you try to like stay up a little bit for like Mia to wake up and then at least see her for a few minutes before you go to bed, or at least let me like bring her into the room so she can climb up on the bed and like give you a hug, and then I like bring her downstairs for breakfast while you try to get some sleep for a few hours. So I think trying to find that balance right now is still a work in progress, but I do think she misses you a lot, and I think like she does show that Like every time he keys in the door or
it's the best part of the day.
Anything, Mia will like possibly be in her high chair, like eating dinner or eating breakfast or whatever it may be. And then she'll be like, Dada, Dada.
Yeah, the best is like if I'm keying into our front door, I can like hear her screaming from the kitchen,
she'll be
from
like,
outside the house.
Yeah.
And she's always so excited. So that's always the best part of my day.
What's something people don't understand about emergency medicine?
I think something that people like the general public and the, average person in medicine even don't understand about emergency medicine is how litigious it can be and how that sometimes drives the way that we practice. And that shouldn't be what determines the way that we practice. And yet sometimes it is. I hear like the common, TikTok quote or something that everyone's complaining that ER docs order CT scans on everybody and just irradiate everybody for no reason. And, the people running the CT tech think that we CT scan everybody because they're only seeing the people that come back there for the CT scans. There's plenty of people that come through the ER that don't get them. And two is, we use these risk stratifying scores for a lot of things to determine whether a patient, needs a CT scan or doesn't. And a lot of times kind of that allowed risk is about 2%. That's what I was taught by one of the docs I work with. So, do we think there's more than a 2% chance based on this algorithm that the patient has whatever serious injury this may be that we're getting the CT scan for? So, to the average person, maybe they think, well, 2% chance isn't that high, but, if you're in that 2%, it's potentially a deadly thing that the ER doc's going to miss. So yes, that means that a lot of the people that we end up ordering these scans on don't have whatever this disease is. And that's just kind of the nature of the beast.
Completely see how you feel like being in emergency medicine and facing this question and like answering this question. But for me personally, like hearing what you come home with, I feel like I at least didn't understand, or feel like other people don't always understand, that like what you see on the day to day isn't always your trauma patient or your massive car accident or heart attack patient. Like you do see a lot of like regular, it could be a psych patient. It could be just someone who like doesn't have access to healthcare and they're coming into the ER, or someone doesn't have established care through the primary care and they could just like need some like antibiotics or like something more quote unquote simple to fix, which like maybe the way I grew up was like you only went to the ER when you like were dying. With my mom being in neurotrauma ICU, she always would say, if you're dying, bleeding, or blood is coming out of your ears, I don't want to hear it. So like those, to me, if you're not dying, bleeding out, or blood is coming out of your ears, like you're not going to the ER. Like you're staying home.
No, I think I mean, I definitely grew up with that bias too, having a dad who's a doctor. Like, I guess, yeah, to your point, like the average person, and not that they're not medically educated. I think there's just a lack of understanding of, how do I want to phrase this? I think it's true that, we're biased coming from two families that had healthcare professionals in it. The average person is not able to discern whether they should go to an urgent care for this, or whether they should go to the ER, or whether it can wait until they can go and see their primary care doctor. If they even have a primary care doctor. I see a lot of people who, they don't really have medical problems because they don't really see a doctor. And then maybe they go to a clinic one day and their sugar is 600 by chance. They feel fine, but they were just, there for whatever. They check a blood sugar and it's 600, and now they, come to the ER because their sugar's so high. So yeah, I mean, there's plenty of benign things that come into the ER, and, we're fortunate that we have a lot of APPs who do a lot of the quote like fast track patient visits. So they deal with a lot of those type of visits. But we do too, as the residents and attendings. So yeah, there is a lot of that. Very minor things that, can seem serious to someone who doesn't really know any better.
No, for sure. I think I even faced it the other day since moving here. Obviously don't have like fully established care yet, delayed with getting an appointment in. And like, to me, it wasn't an emergent need or anything. And I like had called them to try to just get like a script placed. And they're like, well, because we haven't seen you in person yet, we can't give you this. And with it being your appointment's not for a couple more weeks, like, unfortunately, you just have to go to the ER. And I'm like, the ER for this? Like, this sounds like a joke. Like you feel bad walking into the ER because you're like, I know I could have taken care of this like outpatient, but unfortunately, sadly, there's no appointments available between now and then. I need this medication, and this is what I was advised to do. Have you experienced imposter syndrome?
I don't know that I've truly experienced the imposter syndrome. I think, I talk to my friends from medical school a lot, and we're all just kind of like, we don't really feel like we know what we're doing. And, it's not that like you feel like, oh, I shouldn't be here.
That's scary.
I mean, not that we don't entirely know what we're doing, but again, there's obviously a lot to be learned still. Yeah. So, it's not that I feel like, oh, I don't belong here. It's more that I feel like, oh, I just have a lot to learn still. Like, this is the beginning of my training as an emergency medicine doctor. Like, I know that I'm going to be capable of doing all these things. It's just not there yet because we're just getting started. So, I don't know that that's truly like the imposter syndrome that people talk about, because that's more like, oh, I don't think I should be doing this. Like, I don't belong in this role. And, I totally get where that comes from. But, I think you just have to realize that everybody who is just starting residency kind of feels like this. And it takes time. That's just kind of the nature of the game. You're not expected to know everything right off the rip. I think there's kind of an expected learning curve from the faculty, which has been good. And a lot of times you don't know what you don't know till you don't know it.
Yeah.
Which I've had a lot of these first few weeks, which has been humbling, but I get it. And I'm aware that there's a lot to learn still.
Yeah, because I think you go from being supervised as like full on supervised, like 24/7 as a medical student, to then being a resident and still being supervised in some ways.
Yeah.
But probably way more hands off than what you were as a medical student.
Mm-hmm. Yeah. And, the attendings are pretty good about, they want to give you autonomy. They want you to make decisions for your patients, but they're not going to let you kill somebody. Like, they're going to make sure that you're doing something that's appropriate, even if it's not maybe the way that they would have done it exactly. They want to give you the freedom to make your own decisions. And there's variation in practice, even between attending doctors. Not everybody does things the same way. I think the biggest thing that I've seen that with is kind of like pain management in the ER. Some doctors are more willing to give opiates than others. There's not one right way to do it. It's kind of an art, and people like doing different things for different patients. As someone who's kind of just getting into the mode of learning like the different ways to manage pain in the ER, it's kind of hard when you work with one doc who does things one way, and then you suggest that to a new doc who's like, well, I wouldn't do that. And you're like, well, I just worked with someone who did exactly that, but okay. Mm-hmm. But you kind of you pick and choose from different doctors that you work with, or maybe you find something in the middle of what different doctors do, and you slowly kind of form your own way of doing things.
Yeah. And I'm sure too, it comes down to like a case by case basis. And like,
Absolutely.
I'm sure you can definitely tell based on like what patients overall like are here for what needs and based
Mm-hmm.
on pain levels and things too. Like someone who's perfectly sitting up and talking and says that they have 10 out of 10 pain versus someone who's like moaning in the bed and like can't even look at you.
There's a lot of different presentations of pain too.
Yeah,
So
I can't imagine.
It's a hard thing to navigate sometimes. So that's definitely been one of the bigger challenges from a like practicing medicine standpoint for me.
Yeah. What's one thing you've appreciated most from me this first month?
I think the thing that I've appreciated most is just you being there for Mia when I'm not able to. I mean, most of these days it's you for 12 hours of the day, and maybe I come home and I see her for an hour. But you know, you're the one there for her the rest of the time, taking care of her. It's not easy. She's a extremely active toddler. Keeps you on your toes all day, always wanting to run around and do something, always needing to be entertained. So it takes a lot of energy and willpower and patience, and I know that I certainly don't have it right now. So that I think has been the biggest help from you and the thing I appreciate the most.
Yeah. And I definitely appreciate you trying to think ahead, meal plan, whether that's cooking up meat and stuff ahead of time, trying to meal plan for us, because that is not my forte at all.
The 10-pound bucket of chicken at the beginning of the week has been a staple for this last month.
So it's just been so much easier to like throw it into dishes or make me a chicken quesadilla or just like use it to top on salads or whatever that may be. So thank you for taking that time, because you still prioritize us and know that we need to be fed. Even if it's not a gourmet dinner. But you still try when you do.
I try.
I want to take a quick break and let you guys know the best way to make some extra free cash. If you're anything like our family, you're constantly filling up the gas tank, grabbing groceries, or picking up dinner on a busy night. And with prices seeming to go up every week, I'm always looking for simple ways to save money without changing my routine. That's why I've been using the Upside app. Upside gives you cash back on everyday purchases like gas, groceries, and dining at participating locations near you. All you have to do is open the app, claim an offer, shop like you normally would, and earn cash back. You can even stack those savings on top of your existing credit card rewards and loyalty programs. As a busy wife, mom, and soon-to-be residency family, I love anything that helps stretch our budget a little further. Those small savings really do add up over time. Plus, cashing out is easy. You can transfer your earnings to your bank account, PayPal, or choose from a variety of gift cards like Amazon or Starbucks. If you'd like to try it for yourself, download the free Upside app and use my code Morgan45393. That's MORGAN 45393 when you sign up. New users can earn a referral bonus on their first qualifying purchase. Again, that's the free Upside app, and use the code Morgan45393. Start earning cash back on purchases you're already making. Now let's get back to the episode. What advice would you give fourth-year medical students making their rank list?
I would say for fourth-year students making your rank list, you know, and it sounds kind of like, yes, obviously, but this isn't always what goes through people's minds. Like, rank the programs that you could see yourself at, that you want to be at the most, versus like ranking a program that is super prestigious number one just because you think it should be number one, versus one that you like, maybe you enjoyed rotating there, or you really clicked with the faculty during your interview or something like that, that you could actually see yourself at a place. And maybe it's less about like how to build your rank list and more about how to actually determine which programs you like. Cause you know, I think people sometimes try to game the ranking process by saying like, oh, this is like a safety program for me because they're not as competitive. So I'm going to put them lower, even though I really like the program and would love to work here. Like, if you really like a program and you think that it would be a good fit for you, rank it number one, even if it's not a place that's super prestigious or like a big name or whatever. I think for me, that was a big thing was, the program that I ended up at, I ranked one, and it's not a big name program by any means, but it's in an area that I love. When I rotated here, the faculty was awesome. The residents were awesome. The nurses were awesome. And I was like, why wouldn't I want to be here? I had interviews with kind of more prestigious programs that ended up lower on my rank list because, I didn't like the people as much.
Also to note, even if you liked the program, we as a family didn't see ourselves there.
Yeah.
And like that lifestyle and things, because I think you also took into account like my day-to-day life outside of the hospital and how we would handle that and different things like safety and...
Oh, yeah. Yeah. I mean, certain places are safer to live than others. Certain places are more expensive and tight on a resident salary than others. Certain places, didn't have a lot of residents that had other kids. And certain places had residents that had tons of kids. And, I think for me, it was important trying to find a place where a lot of the residents had families. That way you had other people you felt like you could connect with. Because,
we've been so blessed.
Oh,
with
yeah.
that.
No, I mean, yeah, we have a lot of I think we have four residents that have children that are married and have kids. And out of 11.
Yeah.
So, I mean, it's been awesome. We've hung out
honestly,
a lot, had play dates.
More worried that was like a little bit on the lower side for some people, but I feel like everyone who I've talked to of like friends of ours from medical school, they are like the only ones like struggling to find people. And it like absolutely breaks my heart because I'm like, I wish you guys would have found programs that had families, or at least be able to connect in some ways.
And it can be hard to know. I mean,
yeah, the class above you only has
the class above
one.
me has one. I think just one.
Maybe now two, but I think like when she came in, she was
definitely not
one.
as many though. But like the senior class that was leaving, like a lot of them had kids, and a lot of the faculty had young kids, and that was just kind of the vibe of the program. I
think also trying to find like your residency program does a lot for the residents and families. Like this upcoming week, there's an event for all the residents and their families. So I think finding that information out too in interviews or asking what they do outside could be beneficial too.
Yeah. I mean, just generally, I think it's important to ask, questions that are pertinent to things outside of your training that maybe align with, something that you have going on in your life. I don't know of an example of that, but other than like having kids, like
if you are single, do you want more residents that are single?
Sure.
Like it doesn't have to be family oriented.
Yeah. Or if you like love playing soccer, like ask if there's like a club soccer team that the residents play on and things like that. I know that got brought up in a couple of my interviews. Another thing that I think would be important to consider when you're making your rank list, and it sounds kind of silly, but it really does add up, is parking included in, where you're doing residency, or do you have to pay to park in a garage or something? Or is food included when you're on shifts? Do you have access to, the cafeteria? Do you have like a physician's lounge you can go to get snacks and things like that? I know for me, like we park right outside the ER. We walk in, there's no fee. Like there's always parking. So it's never something that I have to worry about. It's another stressor I don't have to worry about when I'm getting into work. We have access to the physician's lounge, which has awesome food. They have energy drinks for us. They have snacks. It's open all the time. And we can also go down to the cafeteria and everything's free. They have more energy drinks there. They have protein shakes and, pretty much whatever food you want. I know it's it sounds silly to pick your program based on like food and energy drink accessibility, but it does add up. I mean, if you think about it, you drink one every day you're there a lot of the days of the year. I'm like, you probably save close to $1,000 just on that alone. And that's not even, considering food too.
Yeah, and I know one other person who's currently in residency at a totally different hospital, and they said that they have to pay for parking. Parking is like basically like 2-3 blocks down the road. Like, it's not close to the hospital. Parking is like a nightmare. And that cuts into your social life. That cuts into your sleep time.
Time is precious when you're in residency. You do not want to spend it walking from a parking garage that's far from the hospital.
Yeah. And when you're coming off of a 12 or 24-hour shift or whatever it may be, days, nights, you're exhausted. Like, trying to then navigate city parking, and even if there's snowstorms or weather, like, you don't really got to think that all through.
Yeah, and kind of, even to go a step further, like, in considering where you're going, are you in the middle of a city in your hospital and all the living right around the hospital is super expensive and you won't be able to afford it on a resident salary, and then your commute is now an hour into work every day with traffic? Or are you, on the outskirts of the city and you can live in a suburb for a lot cheaper and your commute's still not that bad? And, that's kind of where we're at. I mean,
yeah,
we live a little bit outside the city, and my commute to the hospital is not even 15 minutes. Most days I get there in 10 minutes, and it's great. And then I don't have to worry about leaving an hour and a half before my shift starts to try and get there.
Yeah, and I would also make sure that depending on what specialty you're trying to match into, I've heard other residency programs like requiring their physicians to live within a certain radius or like time to get into the hospital, depending on your specialty as well.
Yeah, if you're a specialty that has call, that's
which
another.
Like, you technically do, but not really.
Not really, yeah.
So I definitely take that into account as well, because like, if you have to be within 20 or 30 minutes from the hospital and all the housing 20 to 30 minutes away is insanely expensive, like, think about that. What piece of advice do you have for medical students that's like currently on fourth year rotations?
I'd say a piece of advice for med students, and really not just med students, but I guess anybody, like even residents or really anybody working in healthcare, is just like, be nice to everybody. I know it sounds so like cliche and like obvious, but it's not, I guess. And, everybody in the hospital has a role. They are going to know things that you don't know. Doesn't matter what your role is. Doesn't matter how smart you think you are. Everybody there is going to know something different. And at some point you're going to need to ask them something, and you're going to require their help. And if you weren't nice to them, they're going to remember that. These first few weeks, I have asked so many nurses and techs and secretaries and, anybody who's in the ER where stuff is, how do I do something? And being nice gets you a long way. They're very willing to help. And I think that part of the stereotype, or maybe not stereotype, part of the, people bashing the interns, like, oh my gosh, it's July, the interns are coming, watch out, is that, a lot of the time, if the interns are like, oh, well, I'm a doctor now, so I like run the show, like, that is not the case. I think it's important to, again, be humble, realize what you don't know, and realize that you're going to need help, and that, you rely on everybody that is in the hospital.
Any recommendations for changing from nights to days and back and forth again?
So what I usually try to do, and I don't by any means know that this is the best way to do it, this is just how I do it. I wake up at my normal time. Maybe I try and sleep in a little bit the day before the night shift. And usually I'm okay to just kind of stay up for, 22, 24 hours, whatever it may be. And then when I come home, if I have like back-to-back night shifts, I'll try and sleep like 6 to 8 hours when I get home and kind of do the same thing all over again and fully flip-flop my nights and days. But then coming off of night shifts, I'll try to sleep for like 3 or 4 hours in the morning when I come home. That way it's like enough to get me through the day, but then not too much that I'm still tired around normal bedtime the next night. And then I'll sleep for like 8 hours, maybe a little more that night, and kind of get back into a normal circadian rhythm.
No, I think we've also kind of done well with that recently. Whether Mia's going down for a nap or something, being like, hey, why don't you go lay down with her? Or like if Mia's up later at night or happens to wake up in the middle of the night, if he's working the night shift, he'll take that shift to let me sleep, go deal with her in the middle of the night so that he can
nap
sleep
during
in.
the day before the
or a nap or whatever it may be, so then I can be more well rested, and then he'll be tired, so he'll actually want to nap before the night shift. So honestly, I think that has kind of been beneficial for us, but I'm sure as harder months are ahead of us, that may have to change. Looking ahead, what are you most excited about?
I think I'm just excited to, keep learning and like feel more and more like I know what I'm doing when I'm in the ER. Not having to ask questions about every single patient and, kind of being able to do my thing and just go. It kind of stinks. I mean, it's not the worst thing in the world, but like for me, my next 2 rotation blocks are not emergency medicine. So it's a little weird, like being in the ER, learning all the ER things this month, and then being away from it for 2 months and then coming back. And it's like, it's definitely not going to be like, oh, now I got to start all over again.
Yeah.
But, it's almost like I wish I could have kept rolling with it and then gone and done those other rotations. But, I think ultimately it doesn't really matter. And you learn things as you learn them, and that's that.
I do think the good thing about that, though, is you're still using this same, what is it, like EM or like whatever.
Yeah, it's all the same, like charting and stuff.
Exactly. So like, I feel like if anything, you'll learn more like ways to put in orders or different things like that. At least that way you're not like bouncing back and forth between things.
Yeah, it's not. Yeah, not to say that these next 2 months I'm not going to learn anything about medicine at all, but. It's just not like
OB to EM is a little.
I mean, there's definitely OB patients that come to the ER, but when you're doing OB for a month straight, there's a lot of other things that come to the ER that are not that you have to kind of refresh yourself on when you get back.
All right, last few rapid fire questions, and then we will wrap this up. Coffee or energy drinks?
Energy drinks.
Favorite shift, days or nights?
Days. Early morning shift for days.
Ooh. How many pairs of scrubs do you actually use?
Probably like 4 or 5.
And that's with doing laundry like once a week?
Yeah.
What's your go-to post-shift meal?
Ooh. It depends on the time of day.
Okay.
So like
day shift, getting off a day shift.
Yeah, like getting off of a day shift, I'm coming home and we're having a big dinner, whatever. I don't know. I prepped some kind of meat and carbs. Coming off a night shift, I'm usually not that hungry, to be honest. I'll eat like a protein bar and then just go to sleep.
And then when you wake up, what do you eat?
Oh, and then when I wake up, I'm hungry though. I don't know what I had after my last night shift, but I was starving.
I think you made like eggs and potato, like a whole breakfast bowl.
I had like 6 eggs and a bunch of sausage and potatoes and stuff and like a handful of cheese. It was awesome.
One word to describe residency.
Humbling.
Love it. That's a wrap on this week's episode. Dave, thanks so much for taking the time out of your incredibly busy schedule and sleep schedule to be on the podcast. I know people appreciate it.
Thanks for having me.
I hope this episode gives everyone a little glimpse into what that first month of residency really feels like, not just for the spouse, but for the resident too. If you're starting residency, preparing for match, or supporting someone in medicine, know that this first month is a huge adjustment. It gets better with time, and you're not alone. Thank you all so much for listening. If you enjoyed today's conversation, be sure to follow the show, leave a review, and share this episode with another medical family. Until next time, take a breath, pour yourself a nice coffee, and be kind to yourself. I'll see you in the next one.